I sincerely apologize for the delay, and to make the things more lively, we have with us Professor Dr. Ashok Seth, Chairman, Fortis Escorts Heart Institute. His name probably needs no introduction to the medical fraternity. He has been a recipient of Padma Shri and Padma Bhushan, one of the highest civilian awards in the country, and also the B.C.ROY award for eminent medical person. His records and his credentials probably I am falling short of in introducing, and in the interest of time, I will just say that his records, his credentials do not, cannot be described in words, and his expertise and his passion fall short of anything. So I think Dr. Seth, it's over to you to discuss the Holy Triad in ACS Management. So and a lot of physicians will be interested to know when to do the management of ACS and how to routinely treat their patients. So, sir, it's over to you.
Thank you. Thank you. Hello, friends, colleagues. Thank you for waiting. We know we are 20 minutes late, mainly due to the net, and there was a problem in therefore downloading slides and so on and so forth. But now I'm with you, and thank you very much for taking time out of your busy schedule to go through this discussion with me on ACS. And without further waste of time, let us go to the talk itself so that we can then have discussions around this topic. So we're going to discuss today about ACS management, making the right choice, what are the trials, what do the guidelines tell us, and therefore that is important for our patients as an outcome. So we're going to cover the antiplatelet drugs. We're actually going to dwell on ticagrelor and its presence in the latest guidelines. We're going to cover some of the clinical trials of ticagrelor as they affect our patients in clinical practice, look at some real world registries, and then go on to summarize our thought process. We all realize that acute coronary syndrome is a continuum of disease process extending from a stable coronary artery disease, where one day a soft plaque would rupture, leading to thrombus formation, or an occlusion would happen with say collaterals, and that would give rise to a syndrome of unstable angina or a non-ST elevation myocardial infarction. The unstable angina is rapidly progressive disease. It leads to troponin rises. NSTMI is a variant which is slightly more severe, but these don't result in major infarctions, but clearly are volcanoes showing minor eruptions, which would then transfer in many instances to a ST elevation myocardial infarction where total occlusion of the vessel occurs. And obviously in the initial stages for stable coronary artery disease, antiplatelet drugs are used for secondary prevention, for secondary prevention. In the unstable angina, non-ST elevation myocardial infarction, in addition to antiplatelet drugs, low molecular weight heparin or heparin becomes an important mainstay of therapy. And as we progress to acute myocardial infarction, we have thrombolytic drugs as well as primary PCI as the mainstay of therapy. So in that continuum, we need to understand that an important part in this whole continuum is the antiplatelet therapy. That's common to all phases, be it stable angina, be it unstable angina, non-ST elevation myocardial infarction, and be it acute myocardial ST elevation myocardial infarction. And using dual antiplatelet therapy is an art and a science in itself, because on one hand it reduces ischemia risk, while on the other hand it also increases bleeding risk. And this fine balance of decreasing ischemia and therefore reducing ischemia and improving outcomes, and yet not having increased bleeding risk, is what dictates our present talk. So how do we assess the risk in ACS patients? We realize that those who have had prior MIs over the subsequent years are at a greater risk of cardiovascular mortality compared to those who have not had prior MIs, and that's been well demonstrated year after year after year. And you can see that up to 5 years we're seeing increasingly risks That's males, that's females, and that's the controls. And you can see that it's at least 5 times higher than the controls up to 5 years. And this happens from the non-culprit vessels more than the culprit vessel. So if you have an MI today, yes, the MI after 2 years is not from the culprit vessel which caused the MI today. It is going to be from other lesions which exist in the same patient in other parts of the arterial tree. And therefore, in the remote arteries, there are twice as more MIs than related to the culprit vessel. So actually, the disease is a systemic disease of the coronary arteries, and the tendency to have infarctions at one stage predisposes to subsequent infarctions over even up to 8 years, as has been seen in the Sweetheart registry. So we have in this diagram a combination of antithrombotic agents and antiplatelet agents, and you well know these antithrombotic agents, which are the anticoagulant drugs which are used in this cascade of thrombosis at various time frames to act at various time frames for preventing fibrogen transfer to fibrin, which forms the basis or the framework for clot formation. Out here are the antiplatelet drugs preventing the platelet aggregation, which then combines with fibrin to form the thrombus. And we now concentrating on these antiplatelet drugs. The aspirin, which works through the thromboxane A2 system, clopidogrel, prasugrel, ticagrelor, cangrelor, working through the ADP inhibition system, the new P2Y12 inhibitors as we would call it, and the combination of aspirin with the one of these P2Y12 inhibitors would constitute the dual antiplatelet therapy. We won't go into the 2B3 receptor antagonist, and then this is what we're going to dwell on at the moment. And if we talk about the antiplatelets, we talk about the new P2Y12 inhibitors, and the new P2Y12 inhibitors mainly which we concentrate are on ticagrelor and prasugrel. We know that clopidogrel has been a mainstay of therapy in management of these patients or of our patients, both ACS, acute MI, and PCI for a long duration of time. Cangrelor is an intravenous P2Y12 inhibitor which is not available in this country, so we won't dwell on that. And then we have, therefore we will dwell on clopidogrel and ticagrelor, prasugrel in a sense. When we come to ticagrelor and these new P2Y12 inhibitors, which in common use are prasugrel and ticagrelor, the ticagrelor has the advantage that it binds potently but reversibly to the human P2Y12 inhibitors independent from the ADP. So just in a graphic representation, I don't think that's working because it didn't download well, but basically what it does is that it actually binds to the P2Y12 inhibitors and yet leaves the ADP induced receptor reversible, and therefore its mechanism of action is short. There it is. It binds to the area distinct from ADP receptor site inhibitors. As you can see here, ADP is bound but does not get deactivated, and receptor is left intact upon the dissociation of the molecule. So it is, if we actually compare all this, yes, this is a direct acting P2Y12 antagonist. It is reversible as opposed to clopidogrel and prasugrel, which are irreversible or take a long time, therefore to go away from the body, where the receptors have to be reset after this washout of these drugs. There is a rapid onset both for prasugrel and ticagrelor, but not so for clopidogrel. We see here that platelet aggregation decrease is inhibition of platelet aggregation is greater than 80%, so they're both very effective. Prasugrel and ticagrelor are both very effective. Offset is faster for ticagrelor, and that in a sense can be considered a safety mechanism. As you know that when we talk about how many days after these drugs can one have surgery, you know that for ticagrelor, after 3 days of discontinuation of ticagrelor, a patient can have a major surgery, while for clopidogrel, the recommended duration is 5 days, but for prasugrel, the recommended duration is 7 days. So both clopidogrel and prasugrel disappear from the body slowly. And of course, there are non-responders to clopidogrel, but for prasugrel and ticagrelor, it's extremely rare to have a non-responder. And the adenosine reuptake inhibitor, the ticagrelor is an adenosine reuptake inhibitor. Now, let's move over to the next slide, and I think you could help me to move over to the next slide because it's downloading slowly. So let's see what's the evidence from ticagrelor. Let's concentrate on the two major studies. The two major studies are Plato, which was published in 2009, a study done between 2005 and 2008. And this included close to 18,000 patients with ACS. Excuse me. Unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. I want to emphasize right here that there was no upper age limit. Nearly 15% of the patients were more than 75 years of age, which is usually the upper age limit for most of these studies, most of the antiplatelet and anticoagulant studies. A loading dose of 180 milligrams, followed by 90 milligrams twice a day along with aspirin, randomized to clopidogrel of a 300 to 600 milligram loading dose along with 75 milligrams daily with aspirin, with a median of 277 days follow-up, looking at a combined endpoint of cardiovascular death, MI, and stroke. We can move forwards. This is ticagrelor for 1 year at 90 BD. We'll come back to the Pegasus TV 54 in a while. What Plato showed was clearly a significant decrease in the primary endpoint, the primary efficacy endpoint of cardiovascular events, a 21% risk reduction for cardiovascular mortality. This was very significant. There was no significant increase overall in major or fatal bleeding in the Plato study, which was of comfort. That established the role of ticagrelor in the management of ACS patients. I want to emphasize here, let's go back again, and can we go 2 slides back? Yeah, one more slide back. Now let's come to the Pegasus, which was published in 2015, looking at close to 21,000 patients. And these are patients who are not ACS necessarily. These are patients who had prior MIs 1 to 3 years before randomization. Nearly 80% of these patients, so these are patients, nearly 60%, 80%, I think there was 80% of these patients had also had a PCI in the past. And these are looking at patients with one risk factor for thrombotic events, again, no upper age limit. And what it was done was to look at whether in a stable patient who's had a previous MI, and we know that the previous MI patients are predisposed to having more MIs, especially remote MIs in the subsequent years, can in these patients who are otherwise stable and not unstable, ticagrelor, can it decrease subsequent MIs? So a dose of aspirin, which is the standard therapy for secondary prevention, has been used along with placebo. Aspirin plus ticagrelor at 90 milligram twice a day, and a third arm of aspirin plus a lower dose of ticagrelor. Think of it as a maintenance dose to prevent infarction, followed up over a median of 33 months, so a 3-year study looking at cardiovascular death, MI, and stroke. So here the dosing, a new dosing was tested out in stable patients who'd had a previous MI to look whether a secondary prevention could actually be done. And again, what Pegasus showed was that ticagrelor plus aspirin was superior to placebo plus aspirin in decreasing the cardiac event rate and decreasing MI compared to aspirin monotherapy at 3 years. So that's 9% versus 7.7%. That's important to understand that it was also that, but it was at the expense of some major bleeding, which was significantly higher in both doses of ticagrelor, but was obviously higher in the 90 milligram twice a day dose compared to the 60 milligram twice a day dose. And therefore this also, while it was at the expense of slightly increased fatal bleeding, increased risk of rate of fatal bleeding or non-fatal intracranial hemorrhage, but the lower dose was still better than ticagrelor 90 mg BD plus aspirin. One can argue in this study that if these patients had not been on aspirin and were only on ticagrelor, maybe the bleeding rates could be even further down. So there is an establishment of ticagrelor at 60 mg twice a day as a safer dose for preventing myocardial infarction. So where does this all fit into the guidelines? Plato for ACS and the 60 mg BD dose for stable coronary artery disease patients who already had a previous acute MI, and therefore 80% of those have already had PCIs or have been on clopidogrel. This is how it fits in, and this is the recommendations of 2017 from the ESC looking at dual antiplatelet therapy, that ticagrelor, so it is that in patients with ACS who are managed with medical therapy alone, treatment with DAPT is recommended to continue P2Y12 inhibitors for a period of 12 months, class 1. So DAPT after ACS is class 1. But ticagrelor is recommended over clopidogrel unless bleeding risk outweighs the potential ischemic benefit. So if in most instances, if the bleeding risk is not high, ticagrelor is the drug of choice for ACS patients up to 1 year. Now, when we go on to patients who have, just like we discussed, prior MI at high ischemic risk, who are managed on medical therapy beyond 1 year, then treatment with a DAPT with ticagrelor on top of aspirin can prevent infarctions up to 36 months and is now a 2B indication as of 2017. And that is what is the combination of Plato as well as the Pegasus. We want you to note that out here, while we talk about ACS patients, prasugrel is not recommended for medically managed ACS patients. It is only for those patients who have a PCI, while ticagrelor is a therapy for ACS blanket, be it medically managed ACS, be it PCI treated ACS. And what is the duration of therapy for ACS? We know that duration of therapy as emphasized is 12 months, and then you may actually have continued DAPT on a lower dose of ticagrelor with aspirin for up to 36 months in those with high ischemic risk but low thrombotic risk. Of course, if you have high bleeding risk patients, then the duration of DAPT can be shortened to 6 months. DAPT duration is an important aspect, and that is what this ESC guidelines recommend, that it is 12 months unless there are contraindications like excessive risk of bleeding, and in patients who have excessive risk of bleeding, like having a precise DAPT bleeding score of greater than 25, the discontinuation can be considered at 6 months, and that's a 2A class of recommendation. And of course, we don't need to go over the BVS. We've already discussed continuation of DAPT longer than 12 months, and we also discussed having the 60 mg BID dosage beyond 12 months with ticagrelor. This just represents the same, I think, and irrespective. So therefore, I think the conclusion of this recommendation is that the final revascularization strategy, be it medical or be it PCI for ACS patients, we've got a default duration of 12 months, and 6 months duration can be considered in those with high bleeding risk patients, and the ones with low bleeding risk but increased ischemic risk can be considered for a 60 mg BID dosage beyond 12 months up to 36 months. Now this is an important aspect, switching, and we must understand this in acute phase as well in chronic phase, because what I want you to understand is that this green means class 1. The only switching which you can do at any time from clopidogrel, and we are now talking about ESC guidelines, that irrespective of prior clopidogrel timing and dosing, is with ticagrelor 180 milligrams at any time following clopidogrel dosing. So if you actually look at here, this is type 2A, irrespective of prior clopidogrel timing and dosage, a loading dose of prasugrel can be given. while clopidogrel loading dose needs to be given 24 hours after last prasugrel dose on a switch from prasugrel to clopidogrel. On a switch from clopidogrel to ticagrelor, class 1A anytime 180 milligrams can be given, but 600 milligrams of clopidogrel should be given 24 hours after the last ticagrelor dose. What is important to understand is the switch between ticagrelor and prasugrel, which should be avoided but sometimes may need to be done for various reasons, and that has to be a loading dose in the acute setting. Always reload. In acute setting there's always reload, but it has to be 24 hours after the previous ticagrelor or previous prasugrel dose. I think this has to be well understood. You can't load at any time. While with clopidogrel the loading can happen with ticagrelor at any time as a class 1, with prasugrel at any time as a class 2A, but not with between ticagrelor and clopidogrel. So switching in between is discouraged in between the two new P2Y12 inhibitors, apart from the clopidogrel issue which I've discussed. And when you go to chronic setting, which is very important, I think it's important to understand here that for clopidogrel, here, and this is the chronic setting, we have clopidogrel to ticagrelor, which can be ticagrelor 90 milligram BID 24 hours after the last clopidogrel dose. However, clopidogrel always has to be reloaded with 600 milligrams at any stage. You would actually find this here. This should have also been a clopidogrel. It shouldn't have been a clopidogrel maintenance dose. It would have to be a clopidogrel load. The reason, no, it is a clopidogrel maintenance dose. The reason out here we must remember is that when we shift from prasugrel to clopidogrel, we have a very long washout period, and therefore a clopidogrel maintenance dose can be given 24 hours after the last prasugrel dose, and that will take care because of the long washout period of prasugrel. Out here, because of the short washout period of ticagrelor, a loading dose of clopidogrel would have to be given 24 hours after the last ticagrelor dose. And between the two, as we have prasugrel, as we have a rapid wash off of ticagrelor, when we shift from ticagrelor to prasugrel, a loading dose of prasugrel will have to be given. In a sense, what this therefore means is that when you actually stop ticagrelor for actually changing over to other P2Y12 inhibitors, the next dose has to be 24 hours later, but has to be with a loading dose because of its rapid washout. While when you shift from other agents to ticagrelor, you don't have to have a loading dose. So here, switching from clopidogrel to ticagrelor is recommended early after hospital admission as a loading dose of 180 milligrams and loading dose of at any time after the loading dose of clopidogrel class 1A, as I've just told you. We must also go to this guidelines of 2018, which tell us that irrespective of the which talks about what we've just said, but it also says that clopidogrel is become a second line agent for ACS only when prasugrel or ticagrelor are not available and are contraindicated as in patients undergoing PCI. And we also need to understand that prasugrel in P2Y12, so prasugrel for pre-treatment in patients with non-ST elevation ACS undergoing invasive management, ticagrelor administration can be done at any time prior to the diagnosis being established. But for prasugrel, it is quite clear that it is till the diagnosis is not established, we should not be giving prasugrel. Prasugrel is a drug to be given in the cath lab once the anatomy is known, while ticagrelor can be given at any time prior to the patient going into the cath lab, even before the anatomy is not known, because of its help in rapid washout, but its equivalent efficacy in the long run. Now, what is also important to understand is the 2B indication of use of the new P2Y12 inhibitors, ticagrelor or prasugrel, which can actually be considered, and as in our own practices being regularly used in specific high-risk situations of elective stenting. These are non-ACS patients, these are stable coronary artery disease patients, but these are patients with left main, with multiple stent implantation, with triple vessel disease, who are diabetics, patient with diffuse disease, long stents, long lesions, revascularization of CTOs, perhaps culotte and crushes in the left main, and long segments of rotational atherectomy, extreme LV dysfunction patients who would otherwise be high risk for stent thrombosis and who could otherwise have mortality related to stent thrombosis. And it is now a 2B recommendation to use the new P2Y12 inhibitors in such a situation. One of the other recent studies is the TREAT study, and basically in simple terms, let me just tell you that the earlier recommendations have been that after thrombolysis, as a patient comes to you from another center and he's on clopidogrel, we decide that we want to do a PCI, the recommendation has been 48 to 72 hours is only when we can start the new P2Y12 inhibitors. So if we were doing a PCI within 24 hours of a patient being thrombolized, we would be using clopidogrel as per recommendations, unless 72 hours had passed by when we could use ticagrelor or prasugrel. However, there's this data which is in favor of ticagrelor, early starting of ticagrelor in patients who've been thrombolized by fibrinolytic therapy. This was a study which is the TREAT study, which actually looked at less than 75 who had been thrombolized, many of whom were actually taking clopidogrel, are either given ticagrelor de novo or given ticagrelor as even if they had had clopidogrel, and were randomized therefore to ticagrelor and clopidogrel continuation or switch to ticagrelor de novo. And it is interesting to note that the mean ticagrelor loading time was 11 hours from 4 hours any time, but it was mean of 11 hours after the previous thrombolytic dose, and what it actually showed was there was no increase, it was non-inferior to clopidogrel for major bleeding at 30 days. The rates of fatal and intracranial bleeding are similar between the ticagrelor and clopidogrel group. So the serious bleedings were less common and the same. It was only minor bleedings which occurred. So I think that is a comfort that in the current SEMI guidelines, which was 48 hours, that you could not give the new P2Y12 inhibitors, it now appears through the TREAT study that patients who received clopidogrel after STEMI or those who have been thrombolized can actually be treated within the first 24 hours with ticagrelor and undergo a PCI safely without increased risk of major bleeds. Now, an important issue which we've never addressed and we should be addressing is the mortality in ACS. Till now, really no antiplatelet agent had actually shown to improve mortality. There's cardiac events as a whole, MI, strokes, all could be altered, but no significant benefit with clopidogrel and ASA, and I'm talking about in addition to aspirin in preventing cardiovascular mortality post ACS. And we're now talking about ACS patients. Cardiovascular death was the same in the CURE trial. In the Triathlon 38 trial of prasugrel of ACS patients, again cardiovascular death was not significantly different in the clopidogrel versus prasugrel group. But in the Plato trial, that was perhaps one of the important studies which actually showed in ACS patients a 21% reduction of cardiovascular death and a 22% reduction in cardiovascular mortality with ticagrelor versus clopidogrel, as is seen here. This has been discussed repeatedly, the cause, what is the mechanism, and the mechanism is not just plain P2Y12 inhibition, and that's been well understood. But this has also been seen in other studies of ticagrelor. The mortality benefit, can we just go back to the slide, occurred irrespective. We need to go back again because I think that is not, we need to go back. I want to just point out that whether the initial strategy was invasive or whether the initial strategy was conservative and continued medical therapy, there were still mortality benefits which were seen, and I think this is to be importantly understood. And this was from Plato. You remember in Plato not every patient underwent a PCI, and that's why we have the data for ACS on medical treatment. But whether it was this invasive strategy of 13,000 patients, or conservative medical therapy and 5 actually ticagrelor showed benefits in terms of mortality. When we talk about elderly patients, again the emphasis, it provides an advantage to us, because one of the black box warnings, by the way, of prasugrel is age more than 75 and weight less than 60. And while we understand that perhaps in these patients a 5 milligram dose of prasugrel can actually be used, but that's never actually been proven in robust prospective randomized double-blind studies. But the Plato had a reasonable amount of elderly population. There was no upper age limit. 15% of the patients were above the age of 75. And what do we actually see? So therefore, that is why there is no upper age limit warning for ticagrelor. And when we look out here, whether we look at cardiovascular death, MI and stroke, whether we look at all-cause mortality, MI, cardiovascular death and definite stent thrombosis, and we look at age above 75 to less than 75, we continue to have benefits in the same manner as with ticagrelor. So benefits remain above 75 years of age if compared to less than 75 years of age for all the endpoints, as we can see here, including definite stent thrombosis. So we have advantages. Do we have disadvantages of ticagrelor? Well, we know that even in Plato study, there was slightly increased bleeding risk with the new P2Y12 inhibitors, as was seen in triatontomy 38 as well with prasugrel. And we actually see that the bleeding risks with above the age of 75 are no different to the bleeding risk of less than 75 in the Plato study, as is seen for major bleedings right here, and as is seen for the non-cabbage related major bleeding, as is seen here. So that's a comfort zone that in both young and elderly, or less than 75 versus more than 75, we're doing fine. This is, of course, I just talked to you about it, that these are the black box warnings around prasugrel. I think there's been some discussion regarding the ISA React 5 in the recent times. This is perhaps the only randomized study of ticagrelor versus prasugrel, which showed the data in favor of prasugrel arm compared to the ticagrelor arm in the composite endpoints of MI stroke at 1 year, with no significant differences in major bleeds. This is an interesting study, but I think because it was an open label study, and all the previous studies, by the way, have been double blind placebo controlled trials. This was an open label study done at 2 centers. It had a 90% patient follow up, and it also had only an 80% compliance with medication, I think, 85% compliance on medication. There were early discontinuation of medications. So I think with all those, if we look at intention to treat analysis, and remember there have been dropouts as high as 20% in this study, then of course the significance was there. But if we look at intention, the patients treated and the patients who actually took the drug in both arms, there was no difference between ticagrelor and prasugrel arm. So I think the jury is still not out on this study about randomization. This is perhaps the only study. But given the fact, and I'm not discounting prasugrel, I think it has its own advantages, certainly in some of the areas. But given the wide spectrum of ability to use ticagrelor in a wide spectrum of patients, medically treated ACS, prevention of MIs on the long term, which by the way was negative with the medical treatment with prasugrel was negative in the Triology ACS study, with the ability to decrease MI in patients with previous MI over the next 36 months, with the ability to apply it to a large group of patients without actually having the age or weight as one of the limitations. And obviously, it's an easy drug to use. And actually, if the patient was to actually have a bleed, it's an easy drug which washes off. Well, I think we won't go through the other registries around this, but other registries, other robust registries which are well recognized, like the Sweetheart registry, also showed similar results as the Plato. Now, just a word about what's happening around, and I think I'm going to tell you what my heart is about all this. We now have a lot of, over the last 3 or 4 months or a few months, we have a lot of ticagrelors available to us, and it's in a way a good thing. It brings the cost of the drug down, but I'm very wary of it, and I'm wary because of my experiences of the past. I know of many of such situations. The first time an antiplatelet agent, a dual antiplatelet therapy came in 95 when we started using diclopidine in addition to aspirin. Prior to that, it was really every time we implanted a stent, we would be worried sick of stent thrombosis, which could happen at any time frame, and we'd be using aspirin, Pasantin, Dextran, anticoagulation, and we would be actually keeping our fingers crossed and praying to God. Diclopidine changed it for us, but had its side effects of thrombocytopenia, and soon clopidogrel came afterwards and became the mainstay of preventing stent thrombosis. It was Plavix at that time. I still remember the time that when we switched with the drug-eluting stents, when we switched from Plavix to what was then became a number of clopidogrel became available to us, for a few months we started noticing stent thrombosis in a big manner. And even till date, while this has now got well established and we're now very comfortable with a variety of generics available to us as far as clopidogrel is concerned, it took us 2 years before we actually became safer with the newer clopidogrels available to us. Even till this date, you and I and many of us who have our own relatives sometimes having a stent implanted and have to be on clopidogrel, go back to Plavix as the safe drug rather than others. Now that's just an example, and now there are numerous ticagrelor available to us, and I therefore want to understand that its bioequivalent is assumed that they are therapeutically equivalent, but that's not necessarily the same till that gets proven again and again over a period of time through various studies. And sometimes we do require large studies, we do require differences to be tested, we do require reference products and clinical testing, and unless that is done, the comfort zone is not going to be there, especially when we talk about, very importantly, we're talking about lives of our patients. We're talking about the fact that these are ACS patients who've got a very high risk of cardiac events in the subsequent months and years. We're talking about stent implantation in acute MIs, which have a very high rates of stent thrombosis if we did not use an agent on which we could rely. And of course, we always, I say, do to yourself, do to your patient what you do to myself, and am I ready to use any drug at this time versus the original molecule? Am I in that phase if I was to actually have that? So we need to understand bioequivalence, we need to verify the fundamentals of it. It's impossible to conduct large clinical trials, but we need to understand the bioavailability of these, and any range of 20 to 25% which represents bioequivalence may actually lead to increased platelet activity and a stent thrombosis in that range. So it doesn't actually apply safety to the spectrum of patients we're talking about, which are clearly not the routine low-risk patients, because ticagrelor is being used for high-risk patients, which is not the same as clopidogrel, which is being used for normal risk patients. So we saw this with clopidogrel. Here's the high platelet reactivity with generic clopidogrel, and this was actually documented and seen till we actually got to grips with it. So I think when we look at our high-risk patients who require these new P2Y12 inhibitors, we need to be safe, and we need to be robust, and we need to have better data around all new ticagrelors which become available to us. But anyway, it's a good thing. But we have to. It has to be a greater scrutiny of evidence. So finally, I think I've told you a lot about all these drugs. I think I've summed it up that we are dealing with this high-risk population, and increasingly in your practice as well as mine, we're not just dealing with ACS patients, which truly form 50 to 60% of our patients, but remaining 25% also. It's only 10% to 15% who are simple now. A majority are complex patients, and they fall into anything that we actually talk about, and they actually need potent and yet safe antiplatelet agents which act rapidly, which are effective, which have got robust prospective double-blind randomized data, which are included in the guidelines, and which also have the ability to prevent myocardial infarctions, but whose effect can wear off rapidly if it was needed and a bleeding occurred. We also need robust P2Y12 inhibitors which can be applied to a large spectrum of patients across all body weights, across all ages. And I think that is why clearly in our own practice also, ticagrelor is far more commonly used than other antiplatelet agents. Of course, apart from the routine use of clopidogrel, which does occur. Real world outcomes in patients with ACS treated with ticagrelor versus clopidogrel are consistent with the clinical trials. And of course, as you've just seen, that the guidelines have emphasized the role of ticagrelor repeatedly in the management of our high-risk patients. Thank you very much for your attention.
Thank you, Dr. Seth. Indeed, it was a master class in the management of ACS, and I was actually literally glued to the screen and listening to you in awe and wonder that, of course, your records and your numbers probably do not tell the whole story about your passion with cardiology, and this master class is a prelude to that. So I think we have got a lot of questions and a lot of congratulatory messages from the length and breadth of the country. And Dr. Vineet Sinha, Dr. Venugopal, Dr. Monish, Dr. Ratna, to name a few. So I'll come to the, I'll summarize these questions. I don't think we have time to take all these questions in detail. So the questions which are coming right now, the two things which people want to ask. One is
the dyspnea.
Yeah, management of dyspnea and bleeding.
So Vineet, that's Dr. Vineet Sinha, you raised a very important point because, and it's not a small issue. 20% of our patients do complain of breathlessness, dyspnea. And on one hand, we know that there's a drug which can improve their outcomes hugely. On the other hand, we know it's causing an inconvenience. The way I handle it is, of course, firstly, making the patients understand. Firstly, of course, you've got to rule out that the dyspnea is not due to other causes than just the ticagrelor itself, because you have these patients, our ACS patients, they have impaired LVs, they could have chronic obstructive airways disease, they could have other reasons for having dyspnea. Once you've excluded that and comforted yourself that this is not either ischemia or heart failure or anemia or chronic obstructive airways disease, and then of course you have the first thing is comfort the patient, tell him that yes, this is a great drug which is going to improve his decrease his stent thrombosis, improve his cardiac events, and if he can just live with it and see how it goes over the next few weeks, it'll be good for him. And most patients accept that. And I tell you, by the time 7 days come and you started them and they're actually feeling better, it's rare. And they usually tell you that it's now very uncommon. The second thing is they get it at rest, and it's deep breaths, and they soon realize it's deep breathing rather than breathlessness, and they're fine when they walk. And that's another big comfort to them. And thirdly, I do tell them to have it with tea or coffee. And that's, as we know, helps it, because there's been vague mechanisms around ticagrelor causing this, whether it's related to ADP, adenosine decreases uptake of adenosine, so whether it's extracellular adenosine which is causing it, but anything which counters that seems to help, and therefore we tell our patients to take it with coffee or tea. And finally, it's a rare 2 or 3% who finally will need discontinuation after a few weeks. Now, if that comes and the patient's quality of life is disturbed, and we have these 2-3% patients, we then do transfer them off to clopidogrel if at least 6 weeks have passed by, or if it's very early and we do want the benefits on the longer term of an ACS patient, to prasugrel. But then you've got to follow the guidelines which I actually showed you of transfer. Have that in your pocket on your cell phone, so that you're safely able to transfer the patients from one drug to the other, but avoid transfer is what I say. So actually it's only 2 to 3% patients would ever require transfer. Some of the studies in the West, it's been less than 1% patients.
I think we'll take this question by Dr. Ramesh Raikar, that if MI patients vomit out Brilinta after the loading dose, do we have to load them again?
Yeah, it depends upon when this vomit comes. So you must remember that in an acute MI patient, while we say most of this, after the loading dose, you have the peak effect within 2 hours. In patients who've had morphine given to them, slow gastric motility, post-MI, it can be up to 4 hours. So you must remember these figures. If a patient's vomited after 4 hours, it doesn't concern us, it doesn't worry us. If the patient visibly, and remember, it's always crushed tablets that you give. You don't give tablets per se. So if the vomiting has been within an hour of giving Brilinta, I would reload it without a worry. But if the vomiting has actually been after more than an hour, then I'm fairly comforted because we've given crushed tablets and the mechanism of action is very rapid after having given crushed tablets.
So we'll take this question about a diabetic patient by Dr. G.N. Jagdish. After PCA for a diabetic patient, is it the DPP-4 inhibitor or SGLT2? I think making a lot of noise with the latest data of DEPA, HF.
Yeah, I think that, okay, so I'm in favor of SGLT2 inhibitors, right? I mean, I'm very much in favor of that. Okay. So that is in a sense where we go on this. What else is here? What is the dose adjustment for ACS patients with dyspnea? It's not a dose adjustment. You give full dose. Remember, the only dose of 60 milligrams twice a day is after a year of ACS patients. And if you've got a high bleeding risk patients, then you're anyway going to discontinue ticagrelor at 6 months' time. But after 12 months is the role of 60 milligrams twice a day. And that's what you actually need to be in favor of. 60 milligrams twice a day is a great dose to treat patients for secondary infarctions a year after the previous infarction.
Right.
I think we practically covered everything that we are talking about.
So would I take some final words from you regarding the use of P2Y12 inhibitors and also the SGLT2 inhibitors?
I would dwell on mainly on the topic at hand about ticagrelor and not just deviate away from others, because I think that I would say that at the it's been a great. I think the new P2Y12 inhibitors both are great. There's no doubt. I think they've added a new armamentarium for treatment of our extreme high-risk patients, complex PCIs, ACS, as well as acute MI. They have faster onset of action. They are relatively safe if we understand them and use them judiciously, and they alter outcomes. What is more important is that in our hands, what is easier to use. And it appears at the moment that ticagrelor is more patient-friendly, more doctor-friendly, and yet improves outcomes, both for stable as well as ACS patients, both for patients who haven't had a PCI or have had a PCI with stent implantation, and also for patients who may otherwise need surgery in the very rapid future. So I think overall it's a user-friendly drug, and therefore we are actually more in favor of the use of ticagrelor versus prasugrel. Having said that, I must also say that there's at least a 20% of my patients who actually do need prasugrel for various reasons which we can address, but our primary drug of choice with no age limits and no weight limits becomes a ticagrelor.
Thank you, the audience, first of all, for taking time out from their busy schedules and probably postponing their lunch for a while. And last but not the least, Dr. Seth, I'll thank you for taking out your very valuable time and enlightening the audience. I think it has been a great learning for us, and in times of this virus pandemic, we'll continue with the digital initiatives more often than before. And
yeah, so I think I'm going to be with you for, I think in a month's time, hopefully 2 months' time for SGLT2 inhibitors.
Yes, definitely. I think you have given the final verdict on SGLT2s. The excitement on your face shows this. So I'll just, as a responsible company, I'll request you to please take care of your health. Please stay safe. And
yeah, and thank you very much for all the efforts you're doing for the patients around you, taking all those efforts, being in the hospital, despite what's happening around us. Continue to do that. We should continue to see our patients. We should continue to work. We should maintain the safety standards, educate the patient, and maintain safety standards for ourselves, but continue to work. We are the patient's hope, you must remember, all the time. His hope is us, and we've got to be there for him whenever he needs it. Whichever the circumstances, however bad the circumstances, we've got to stand straight, erect, and help him. So we are here for the nation. You continue to be there for the nation, and this will all pass off, and everybody would be happier and brighter in just a few weeks from now.
Thank you all. It's over and out from Delhi.
Thank you.